Okay. So thank you for joining us, and don't worry, we'll be looking at the World Cup scores for you and updating you. My name is Judy. I still hear some people speaking louder than me, which is, I mean, what part of silent clinical trial don't you understand? Okay, good. So I hope that you're getting very inspired, you're making friends, and you are still eager to understand the ethical issues around AI. My name is Dr. Gishoya. I'm a radiologist, and I work at Emory University. I do work at the intersection of artificial intelligence, one, building the vast data sets, looking at how algorithms work in the real world setting, and evaluating AI for bias. So this morning we started off with hearing how to evaluate AI in the real world setting. And I can tell you the word silence has brought a lot of debate, even in group 5. So please, 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 can you talk to the previous presenters to make sure that you understand their work, because this is why we're here, and that this is such an important group that you will be making decisions, and we do want to make sure that you go home with the right information and the right contacts, because you're going to be making a change in the areas that you're in. So moving on from the morning, for the people who are dozing, we then went to the real world applications, right? I have to cover my ear just in case someone is collecting some data around it, but we saw dermatology applications, we understood some data stored outside the countries that they are collected, we're learning, but the most important session is about to begin. So this is theme 3. And it's about collaborative initiatives and data resources to support AI health research. I don't know how many of us have heard about the UK Biobank? Okay, that's good. How about all of us? Oh, okay. So what essentially these big programs are longitudinal collections about healthcare, collecting images now for the UK Biobank, collecting labs, collecting clinical information, collecting where you live to understand how disease comes and how it evolves. So we will be hearing from from Joan, talking about how she is thinking about the DAWA project, which is a project to longitudinally track, thousands of patients who and study non-communicable diseases. And the good thing about Kate is that she's really in the planning session where we want all ethicists to be involved. So this is your golden chance, and that you'll be providing feedback and understanding how she's thinking about the ethical issues. And I hope that this is going to provide her some information and contacts that she can use for her work, but also that is going to inform a project that even if it may not work for me, it's going to work for our children in future. It turns out that Dr. Kate from King's College has actually supports many applications, and some are amazing, looking at wounds, looking at autonomous AI, and is really, to be honest, she has such a big portfolio, but we asked her to speak about trustworthiness. How will we trust some of the AI systems? But more importantly is that we want to leverage her expertise, her real-world expertise, that she has supported many projects that they fund, and how these projects, what have they learned? Because the problem is with ethics is that it's kind of sometimes up in the air, aspirational. We want to make sure that we can go home with practical things that help us understand how to design our projects and how to move forward with the project. So that's sort of like the spectrum we have. One that's starting and one that is has lessons failed. So please pay attention to that slide, and I hope that we're going to have interesting and engaging conversations. As I promised, I will be keeping updates on World Cup. So, Joy, karibu.
Hi everyone, my name is Gakii Masunga and I am a postgraduate research fellow at Harvard Medical School, and today I will be presenting on the ethical considerations in implementing an initiative that we are just starting called the Data Advancing Wellness in Africa project. So the Data Advancing Wellness in Africa Studies acronym is DAWA, and that in Swahili stands for medicine. And we really like this acronym because it aligns with what we're hoping that the DAWA project achieves. So the aim of DAWA is to create an African non-communicable disease big data commons to collect and analyze big data to better understand the determinants of cardiometabolic diseases and mental illnesses across sub-Saharan Africa. So the use of data science, we're hoping, will enable us to precisely identify high-risk populations and the interactions between behavioral, social, environmental, and economic determinants of health risk factors. Creation of this NCD data warehouse will be made possible by integrating and harmonizing data from various sources. The first source is medical claims outcomes data from various health organizations' databases. The second will come directly from participants who will be enrolled in the study, and they will provide questionnaire data using a geotagged smartphone app. And we will overlay this data from publicly available geospatial data sets. So there are different considerations to be made in regards to the data we're collecting prospectively versus the data from health organizations' databases. In the case where data is being retrieved from various health organizations, understanding how the data was collected may help us mitigate bias. So we'll look to be aware for whether certain protective or sensitive groups were excluded in the data. And in the African context, these would include people from certain tribes, clans, and religions. If this is the case, post-processing may need to be done to enforce fairness. For our prospective data collection, concerted efforts should be made to ensure that data collected covers these groups. Also, because we're using a mobile phone app to incorporate a wider participant pool, we're considering using voice-enabled questionnaires so that participants who are not able to read and write can be included. So what is the importance of conducting a study like DAWA? Over the past 2 decades, there has been a surge in the NCD burden in sub-Saharan Africa, and this has been driven by increasing incidence of cardiovascular risk factors, such as unhealthy diets, reduced physical activities, obesity, and air pollution. In 2009, the WHO NCD Progress Monitor showed that NCDs accounted for 37% of deaths, which is a rise of 13% since the year 2000. This trend shows that NCDs are on track to overtake infectious, maternal, neonatal, and nutritional diseases combined as leading causes of death by the year 2030. This therefore underscores the urgent need for reliable data about the distribution of NCDs and known risk factors, how they change over time, and how they relate to NCD outcomes. Large long-term cohort studies, like the UK Biobank that was just mentioned, in Western nations have been vital in determining disease etiologies, generating hypotheses for randomized controlled trials, and their results have helped shape national health policies. However, due to combined effects of undernutrition, infectious diseases, and other environmental factors, NCD findings from these settings may not be applicable in sub-Saharan Africa. For example, HIV and TB have been shown to be risk factors for cardiovascular diseases and diabetes, and the high prevalence of these factors in sub-Saharan Africa might allow for us to better understand some of these associations. We therefore need our own large epidemiological studies. Cohort studies of this scale, where hundreds of thousands of participants are involved and followed over 20 years or more, do not exist. In 2019, a scoping review to map the extent of current NCD research from large prospective studies was published in the Journal for Global Health. And studies that were included in this review had to have at least had one or more major risk factors other than age and sex, a minimum of 500 participants, 2 data collection points, and at least 12 months of follow-up. The review identified 30 cohort studies from 18 countries, and as you can see from the map, 20 of these studies were in adult participants, 3 had children, and 7 were mixed with children and adults. The largest cohort had 33,000 participants, and this followed minors. And the median participants was about 2,000. So in order to establish whether it would be feasible to conduct a study like DAWA, a pilot study was conducted in 2008. Based on country-specific considerations for retention that is critical for a cohort study, populations were selected for educational background, diverse geographic and socioeconomic status, and working relationships in the community. The study took place in Uganda, Tanzania, Nigeria, and South Africa. Participants were randomly selected within target groups ranging from urban and peri-urban village residents, teachers, and healthcare professionals. The sites used a 6-month follow-up, and consent and data collection was through a mix of face-to-face and phone interviews and paper questionnaires that participants returned to the researchers. The consent forms and questionnaire were also translated to various local languages in Tanzania, Uganda, and South Africa. And the data that was collected from the questionnaires was socioeconomic data, infectious and NCD diagnoses, mental health and injuries, risk factors, including smoking and alcohol use, a comprehensive food frequency questionnaire harmonized across all sites was used to allow for cross-country comparisons. And some questions on physical activity were adopted from the WHO STEPS instrument developed for use in resource-limited settings. Blood pressure, weight, and height was also collected. So a total number of 1,415 participants enrolled with a median age of 41 years from 14 ethnic groups, and 2/3 of the cohort were female. 50% had access to clean burning fuel, 70% had access to piped drinking water, and 92% had access to mobile phones. At the 6-month follow-up, 68% of the participants completed the questionnaire. The prevalence of chronic diseases was 49% among participants between the ages of 45 to 54 years and was dominated by hypertension. Of note, 80% indicated willingness to provide a blood sample. So participants are at the crux of the success of a study such as DAWA, and we're asking these participants to provide considerable data that will include sensitive health information, which raises the questions of autonomy and privacy. Additionally, establishing trust and trustworthiness is paramount, particularly situated in the context of historical exploitation of the African continent. It is therefore important for the consent process to be very transparent. Also important is ensuring that participants know how collection of this kind of data will potentially benefit them. Related to this, regularly sharing with participants research outputs that highlight the impact of their contribution is another way of fostering trust. Lastly, soliciting feedback on their experience with the study and implementing their feedback and changes based on this may also aid with the retention. DAWA will also be a collaborative initiative across 4 African institutions and 3 based in the US. There is an undeniable power differential among the institutions that could alter in-group relations and participants' willingness to disclosure negatively impacting the study. For study success, mutual trust and respect needs to be established, fostering a culture of equitable collaboration. So we are relying on the widespread penetration of cell phones across Africa to make DAWA possible. However, the WHO Ethics and Governance for AI for Health report shows that women in LMICs have less access to cellular phones and the internet. Therefore, concerted effort needs to be made to ensure that women are recruited and participate and adequately represented in the data sets. So lastly, some of the challenges that we've identified that we may be faced with include retention of the participants over years. So we're hoping to do the study long term. So, and the pilot study that we conducted showed that there was a 68% attrition. And part of the feedback from participants was that they were either too busy or felt that the questionnaires were asking, the data that we were requesting was too personal. We'll also be relying on self-reported data, and therefore the question of accuracy of the data provided comes into play as well. Participants may also be wary of who will have access to their data and how this will impact them. Lastly, how to ensure and we foster cohesion among the research teams is another major consideration that we need to make. Thank you.
Okay, we are running on time, so some questions for Gakii.
Thank you so much for the presentation. I think very, very informative. Oh, I need to stand up. Yeah, so, I mean, this is something that you're about to start, I mean, the study, right? And then you are putting measures in place in terms of how you're going to go about data collection. Just curious though, I mean, the complexity of data integration across multiple systems in different countries. How many countries are there in that?
4.
Four countries, yeah. So the complexity, I mean, even within one country, one may imagine if there are multiple systems sharing data, what ethical issues may come out of that, even the complexity on the technologies, that are there. So perhaps maybe there's a framework that you are, or a couple of frameworks that you are looking into to guide how you're going to go about that. Just that maybe you should just highlight us if there's any model or framework that you want to adopt to inform your integration while adhering to ethical issues. Thank you.
Yes, so that's a very important question. Right now, we don't have that figured out yet, but like you mentioned, that is very complex, and we're working on that right now.
We have another question.
Are you planning ethics? Will you seek for ethics clearance from each of the countries separately?
Yes, that will be done.
So thank you very much. You already informed us that some of the participants, I have to stand up like a chief. So you already informed us that some of the participants have already raised concerns, particularly about the nature of the information that you are collecting. For example, with regards to issues around privacy. What steps are you planning to take to ensure that you're addressing those concerns?
Yeah, so the issue that the participants were raising was whether they want to give us that kind of data. So I think the ones who said that they didn't want to continue participating in the study, it's just that they felt that the questions were too invasive. So because we do need that kind of data, so I don't think those participants would be included in the study anyway. But as far as privacy goes, we are ensuring that we use community-based study coordinators, and so we're hoping that having those in place will make people more comfortable in participating in the study.
Yes.
It has to be recorded. Perhaps not. Stand up. Any other requests? Okay. Thanks, Gakii, for that interesting study, which is quite thought-provoking, I think, in some senses, especially considering the previous panel, where we observed that those three initiatives, that was one of the last comments, right? The three initiatives, private companies own the IP. Harvard University is not entirely, an innocent player, a bystander in thinking about the global order of the world and the politics of knowledge and so on and so forth. And so I think what your study really raises, or your presentation provokes for me, is questions about equity, right? Science equity, so not health equity, but science equity. So how do you think about that? And some of these questions I think we've dealt with, or we've kind of encountered in the context of something called H3 Africa, where we had profound questions. Gertnet is looking at me because he was a collaborator on that as well, as was I and others. Questions about data sovereignty, right, in this space. Like you speak about the objectives of creating an African non-communicable disease data commons. But what is the idea of the commons that underlies that objective, right? And who accesses that common effectively? Who controls the data? How do you work through questions of equity? How do you think about benefit, right? And how do you link with other work that has gone on on the African continent that has emphasized again and again the importance of African intellectual leadership over the direction of scientific development on the continent? So you can't answer those questions, but I just wanted to, or maybe you can engage with them somewhat. But I think these are the kinds of questions that seem to me to be really important in this space, particularly understanding this periphery and core dynamic in a lot of the work that you're proposing.
Yeah, thank you for that point.
Okay, no more questions. I do have one. Especially thinking around social, this is going to be a good question, but thinking around social markers of health. So for example, in my village, a cow means nothing. A cow is a cow. But in a different village in Kenya, a cow is everything. And people had rather die of hunger before they eat that cow. And so some of the previous work that's been done in this space is saying, let's figure out the income of households or the wealth using the number of livestock that they have. Have you thought of some of the markers that we can use that are very contextual from an African point of view, which even in Africa there's such diversity even within a country that when I come to analyze your data and say poverty maybe is a big contributor to NCDs, just as an AI researcher, how will you rethink your design of the data from the word go to even address something like a mark of poverty?
Oh, yeah, that's a very good question. And in thinking about how to address the question of socioeconomic status of each participant, yeah, that's a good point, like incorporating, thinking about different communities and how they consider wealth to be distributed. So that's something I think that we need to consider.
Well, we will be having more discussions, but we will let Dr. Keith speak. Please allow some hand claps. Thank you.